Hi, I'm Ross Camidge. I am the Director of Thoracic Oncology at the University of Colorado. Osimertinib is a third-generation EGFR inhibitor, and it's often used as the first-line treatment for advanced EGFR mutant lung cancer. Its original license, of course, was in the second-line setting for patients who had a first or second-generation drug who developed T790M, but that's really kind of yesterday's paradigm. But these treatments are not a cure. We know that people will develop acquired resistance after many months, usually on these drugs. And the question is, why are they developing acquired resistance? Well, the first thing is you can get on-target resistance mechanisms. And the best described is something called C797S. So that is another EGFR mutation occurring in the kinase domain in cis with the original EGFR mutation. In that situation, it's called a double mutation. Now, if you had gone first-generation drug, developed T790M, then osimertinib, then developed C797S as your mechanism resistance to osimertinib, you now actually have three mutations, the original one, T790M, and C797S. That's called the triple mutation. And the good thing is that although these are currently not targetable, so C797S is not actionable in the setting of osimertinib, it's a resistance mechanism to osimertinib. It's debatably actionable in the setting of a first-generation drug, but people are developing drugs that work on both the double and triple mutants in clinical trials. But that's only part of the story. The C797S probably arises barely in only about 10% of people post-initial osimertinib, and maybe only in about 20% of people when it's built on the backbone of T790M. So what's going on in the rest of the people? Well, pretty much everything is on the table. Anything that you can think of that can drive a cancer cell can turn up in this setting as a mechanism of acquired resistance. So we've seen RET rearrangements, ALK rearrangements, KRAS mutations, BRAF mutations, MET amplification, and some of these are actionable. So essentially what you have to do is you have to rebiopsy the patient and do the whole broad spectrum next generation sequencing panel all over again, because anything can come in as a second driver, and some of them are actionable. Now, mostly this is case report stuff, but there are reports of people adding in a RET inhibitor when there's a RET rearrangement, an ALK inhibitor when there's an ALK inhibitor, even a BRAF-MET combination. Now, if you do this, don't just assume you can jump in with full dose of all of these drugs. This is not a pound cake recipe. You have to probably do the equivalent of a phase 1 study in each individual patient. You might keep them on the osimertinib, that's your backbone, and start maybe less than what you would expect as the recommended phase dose of some of these other drugs, and then go up. And as long as you can get around the tolerability, and you probably work with your clinical pharmacist to check there's not too much in the way of drug-drug interaction, you can get these cancers back under control. In terms of clinical trials, what people are working on mostly is the MET amplification. So there are people with MET inhibitors trying to develop this as another labeled indication. MET amplification is a mechanism of resistance to osimertinib. The challenge there is amplification is a continuous variable, 2 copies, 3 copies, 10 copies, and it can be measured in different ways. By fluorescent in situ hybridization, where you actually count the number of dots relative to the centromere on chromosome 7, where EGFR sits, or next generation sequencing, where they'll describe the copy number of MET as amplified, but the question is relative to what? Relative to something in a bioinformatics package, which is a little bit of a black box. At least in our practice, we still do MET FISH testing because at least you know what you're looking at. It's the cellular assay, you can see it. The amplification by next generation sequencing, I'm a little skeptical for. But the headline here is these things are not a cure. You will get acquired resistance. Sometimes it's oligoprogression, you can zap it with radiotherapy, but when it's too widespread, or it's happening too frequently, or it's in a place that you just can't give radiotherapy to, think about rebiopsying, and don't overthink it. Just send off the whole panel. And when you see something that comes back that's broken every rule that you've learned before about these things being mutually exclusive, this is the time to think outside the box and see if you can combine things together, or contact your local expert for better advice.